Welcome in if you're joining and you can hear us. We're excited you're here.
Yes, welcome everybody. We're going to give it a couple more minutes for some participants to continue to join, and then we will kick things off. Mhm.
Maybe people want to put in the chat like where they're from or dialing in from. I feel like that's always fascinating to see. I know everyone's all over. I'm in Connecticut, I'll just say that, close to New York City, but Connecticut is actually where I am right now.
Great.
I'm
How's the weather in
New York.
Connecticut, Lily?
I think similar to New York, it's blue skies today and sunny, and it's like 30s-ish, so feels like summer after the 20s and the zero. So I'm happy with that.
For sure.
Is anyone joining us from a warmer climate? I have some friends who are down in North Carolina. They said it was 78 earlier this week. 78. I was so jealous.
Yeah,
Oh my
that's
God.
what we have in about Austin is definitely in the warm 70s. We pretty much didn't even get a winter.
I wouldn't mind that, to be honest with you, compared to what we've got going on here in New York City in
Yeah.
the Northeast. Okay.
All right, I will go ahead and kick things off. First of all, hi everyone and welcome and thank you for being here. I'm Amber from Zencare and I'm really excited to kick off our first webinar of 2026. This session is part of our broader commitment to the therapist community to provide a free, high quality tools and resources that support your professional growth. Today's topic is one that we hear about again and again, eating disorder competence. Most therapists actually receive little to no formal training in eating disorder treatment during graduate school, yet it shows up in every modality and specialty. If you've ever wondered whether you're qualified to treat eating disorders, worried about missing something important, or questioned how to build the competence without doing harm, this webinar is for you. Um, a brief agenda for this webinar. Today, we will basically be covering a few things. One, why eating disorder training is urgently needed. The three-pillar foundation every ED-informed therapist should understand. What competent treatment looks like through some case examples, and when and how to transfer to a higher level of care, and then the next steps in building your competence. And we are honored to have our clinicians Lily Thrope of Thrope Therapy and Melanie Rogers of the Balanced Eating Disorder Treatment Center. Both of these speakers today bring deep clinical leadership and expertise to the conversation. So, with that, I will hand it over to them to do a more formal introduction.
Wonderful. Thank you. And before you jump in there, Lily, if I may, just seeing in the Q&A section that we need to switch on chat and also are we able to unmute people should they have a question, or how would you like to handle that piece?
Let me work on the chat piece
Yep.
and we will do that. And then if anybody has questions, we have a dedicated Q&A section at the end, and that's when we will allow people to submit.
Great. Thank you.
Amazing. Thank you so much for introducing this important topic. I'm really happy we're all here today. I think one of the things I hear most from therapists is that they don't feel competent working with eating disorders. They feel afraid of eating disorders. So I hope today we can give you a little bit more, understanding and confidence when you are noticing some eating disorder behaviors in your clients. So I'm Lily Thrope. I'm a licensed clinical social worker. I have a private practice in New York City, Thrope Therapy, and we are an anti-diet, weight-inclusive practice. And I started working with eating disorders about 8 years ago, which feels crazy to say. I feel like I'm just starting out. I don't know. It always feels like a new day every day, but I'm really passionate about helping people unlearn diet culture and navigate living in this world in a larger body, which can be really challenging. And I have been on the Zencare platform for 2 years, and it's been a really great place to connect with other clinicians, learn more about marketing my private practice. I like that I can list my entire group practice, and you can see all my clinicians on there, which is really special and different from Psychology Today. I also like that they allow their providers to be featured on their Instagram and share a little bit more about their specialties as well as their blogs. I will say my blog that I wrote for Zencare is one of my most clicked pages on my website. So just a push to try to get featured in the Zencare blog because that's a really wonderful place to be featured. And why do I work with eating disorders? Why is this so important? I am an eating disorder recovered person. I don't know, survivor sounds like a weird word, but yeah, I'm someone who has lived experience with an eating disorder, and I think it's so important to have competence in this area. So I'm passing it off to Melanie from there.
Thanks so much, Lily. And we'll go to our next slide. Thank you. What a pleasure it is to be here today. And a big thank you to Zencare and also to Lily. My name is Melanie Rogers. I am a registered dietitian and eating disorder specialist, and I'm the founder and CEO of Balance Eating Disorder Treatment Center. We're an outpatient eating disorder treatment center here in New York City. We offer a PHP and an IOP level of care along with individual nutrition sessions. So if you do need a nutritionist to join your team, if you're working with clients with disordered eating or eating disorders, we can certainly support you with that. Similar to Lily, I think that we're so aligned on so many areas. I also have my own lived experience with an eating disorder. And that has also been a huge motivator for me as far as wanting our community of professionals to be more informed with how to provide care. Because as we all know, none of us get training in eating disorders. And what is shocking, and we'll touch upon this today in our webinar, is our psychiatrists even do not get training in eating disorders, nor do our pediatricians. So if you think about probably the two professional areas where you would maybe assume that there would be some training, there is none. So hopefully today will provide those of you who are joining us just an overview of some of the key aspects of working with these complex clients, and to boost your confidence if that's what you're wanting to do, is to learn how to work more with these clients and support them on their recovery journey, or at the very least to just be able to know what to ask and how to screen to be able to refer on so that your clients can find and receive the kind of care that they would need to go through their recovery journey. And I hope that at the very, very least today, we can leave you with the idea that we do know that clients can fully recover from an eating disorder. And it is a long journey, but there is hope there. Good treatment, however, is an essential piece to that. And we'll talk more about what those aspects are. Let's go to our next slide.
Yeah, I love that you added that piece that full recovery is possible. And I think that's a misconception about eating disorders. So I'm excited to get into that later. So, why is this training urgently needed? There is such a high prevalence of eating disorders. I forget the exact stat, but it's like 1 in 9 people or something over the course of their life will report having an eating disorder, or be diagnosed with an eating disorder. And they appear at all levels of therapy, inpatient, outpatient, also in schools, and anywhere you go, you can see eating disorders. With it crosses all, cultural backgrounds, economic backgrounds. This touches everyone. They're often missed or misdiagnosed, and I think Mulaney just touched on an important point. A lot of doctors don't even notice when there's an eating disorder going on, and therapists can actually be the front line of defense for eating disorders and noticing, and might be the first people that get a client to have awareness that they need a higher level of care, or they need more support, or deserve that support. I really like to use that language. So this is also an opportunity to figure out, if you might have been doing unintentional harm during your work with clients, if you are unaware of some of the language of how to work with eating disorders. Sometimes you can unintentionally reinforce some of the eating disorder symptoms that we see. There's also an emotional and ethical weight of eating disorder work. Obviously, these are unfortunately very deadly disorders, and there is a high death toll to eating disorders. But there's also a ton of resilience, and there's so much beauty in being able to work with this population. And I have found it so inspiring to sit with people for that long journey that Mulaney was talking about. And this quote here is great. You were trained to treat humans, but eating disorders come with a medical, behavioral, and psychological risk that requires specialized knowledge. So today we'll talk about, how you can notice that and when it makes sense to refer out. Next slide. Yeah. So we want to do this little poll, and I always make this joke that when I meet other therapists, I say I work with eating disorders, and they always say, I wouldn't touch that with a 10-foot pole. It's so scary. And we'd love to actually know, like, what is your biggest fear about eating disorders? I hear that it's a fear that people have. Is it saying the wrong thing? Is it the medical instability? Is it not knowing enough? Or is it maybe a liability concern? And maybe it's nothing on this poll, but we'd be interested to hear if one of these are, your biggest fear in working with eating disorders. And if it's something different, maybe you can pop that in the chat if the chat is active. And if not, we'll do that at the end. Yeah. Okay. So we're hearing that not knowing enough about eating disorders is the biggest fear coming up for everyone. So today is going to be really great for covering, what do you need to know to be able to notice eating disorders, recognize eating disorders, and refer when it makes sense.
Terrific. Thanks for that, Lily. I love those polls. That's great to know. So what I'm going to be covering over the next few slides, team, is the kind of three-pillar foundation every eating disorder therapist would need to be able to understand the acuity of what you might be seeing with your client, and then who's on the treatment team, and then how do you refer. And I will say this before we even jump in. A good treatment centre will communicate with you, should you refer your client to them, will communicate with you at the initial intake assessment period to get your very, very valuable insights on your client, because you're usually the expert because you've been working with the client often for some time. And a good treatment centre should also be communicating with you weekly to give you updates on the status of your client and then discharging that client back to you. That I just want everyone to know that that is the protocol and the gold standard of treatment as to how the industry, if you will, or the field regards and thinks about the referral system and making sure that that client comes back to the referring person. So as we jump in here, so pillar one, clinical understanding, an overview of eating disorder diagnoses. I'm just going to speak about the three key eating disorders and just give you the simplest broad spectrum overview. When we think about anorexia, and by the way, if you think about point two here, as far as how do eating disorders present differently than the stereotypes, for most of your clients who are in your practice, if there is someone with an eating disorder, which statistically there will be, you may never know by looking at them. In fact, the idea of a very, very, very frail, skeletal-like anorexic client, which is often portrayed in the media, is a very rare sight. And even at our treatment centre, we very, very rarely ever see a client that I could see on the street and have a sense that something is wrong. So I want to also say that if you're worried that, my gosh, I might have missed something, the reality is you probably have, and it's because it's not obvious. So the only way we can know is through screening, and we'll get into that. But an overview of eating disorder diagnoses for our clients with anorexia, and I'm going to include atypical anorexia in here, and I'll explain what that means in a moment. Anorexia, as you well know, I'm sure, means significant amount of weight loss, and then at that weight, the fear of regaining weight is so significant and so distressing that the client refuses to regain weight, even if they have health consequences. So those are two of the parameters. And the third is body image distress. So for anorexia, very simply, those three key things: immense body image distress, recent weight loss or weight loss below what is healthful for that client. For a female, that can often mean biologically female, that could often mean a loss of menses, but we've removed that as a criteria because we now know that 25% of our eating disorder population are biological males. So obviously that's not applicable. Atypical anorexia is also a form of anorexia, and it's far from atypical, actually. In fact, it's the most common form of anorexia. Atypical anorexia is where someone has lost a significant amount of weight, is terrified to regain weight, has immense body image distress. However, the end weight that they have lost weight to would put them at an average BMI or at a slightly higher BMI. So in other words, their body shape is still in the norm, or what is referred to as a higher body weight, as opposed to a very underweight body. That is the only difference in the difference between atypical anorexia and anorexia. And I think that not only is atypical anorexia far more prevalent, it's actively congratulated in our society as well done with your recent weight loss, and to screen, because often our clients who are reaching for GLP-1 RAs, the Ozempic, Wegovy, Mounjaros of the world, and Zepbound, are actually pharmaceutically inducing anorexia. And this is something our field is very, very concerned about. So let me talk about bulimia and then binge eating disorder. So bulimia is when a client is often restricting as well, and then towards the end of the day may get so physiologically distressed with hunger, they start to eat, they end up binging, they eat objectively a very large quantity of food in a short period of time. They feel enormous distress, and the only way to feel less distress is to purge. And that client then gets up the next day and is very resolute to restrict that day to make up for that binge and purge the night before. To meet criteria for bulimia, you only have to be doing that process one time a week for 3 months. So as you can see, the diagnostic code or the acuity doesn't need to be every single day or twice a day, though a lot of our clients are doing that at that frequency. So it's once a week for 3 months and you meet full-blown criteria for bulimia. Binge eating disorder is very similar to bulimia, meaning a lot of restriction throughout the day and under eating, objectively large amount of food eaten, often at night, in a binge-like approach, enormous distress, but no compensatory behaviors. And often our binge eating disorder clients will then fall into what they call a carbohydrate coma, or a food coma, our clients will often call it. And so there isn't any compensatory behaviors. For our binge eating, the same as bulimia, binging once a week for 3 months meets full criteria for binge eating. So those are the 3 most common eating disorders. And from just the behaviors, I would encourage you to think about what kind of questions might you be able to ask your client to get a sense if any of these behaviors are going on. One of them is to ask your client about their relationship with food, their relationship with their body and body image. And those simple questions can open up a whole conversation that may get deeper into if there are any other symptoms going on. So how eating disorders present very differently than the stereotypes. I mentioned earlier about the stereotype of what a client with anorexia may look like. But the bottom line here is that you wouldn't know. Most people walking around with an eating disorder look normal. And therefore, the only way that we can know is to screen. And often I've been asked, well, won't the client tell me if they're distressed and they have an eating disorder? And the answer is actually no, often not. And even if you do screen, you may not always get the most truthful answers. And I relate that to, let's say, substance use, right? We usually screen for substance use with our clients. And sometimes we'll get truthful answers and sometimes we'll get kind of some omission there, but we do screen for substance use. And so I'm hoping the very least we'll start to do all of us is to screen for eating disorders as well. Co-occurring disorders and diagnostic overshadowing, it's everything that you're already seeing. And I would suggest that you already have clients in your sessions who have disordered eating or an eating disorder, because we never have plain vanilla eating disorder without any other co-occurring. It's usually a compilation of anxiety and depression. Almost all of our clients have anxiety and depression. All of our clients have trauma, whether it be big T trauma or little t trauma, mood disorders. And then I also want to draw attention to ADHD and neurodivergence. There is recent research that suggests that ADHD and neurodivergence may be its own independent risk factor for developing an eating disorder. Some of that could be related to, for those clients who have time blindness, or they whereby they're just unaware of the time and they've missed a couple of meals. Now they're starving, they go to eat, they end up binging. They feel distressed because they've overeaten, they may end up purging. You can see how the onset of bulimia could start from those behaviors. The other piece with ADHD is our clients often talk about, with executive functioning challenges, how difficult it is to plan around getting to the supermarket and planning meals and having food in the cupboard. And again, these could set people up for inconsistent food intake, which can then set up a disordered eating pattern or even an eating disorder. And so then our fourth point here on pillar one, core concepts every therapist must know before treating eating disorders. I think that, as Lily said earlier, these illnesses are, we believe now, it's about 9 to 10% lifetime prevalence. So they're far more prevalent than we ever thought. We used to think they were about 1% or less, which is why we don't get training. And second to the opioid crises, they have the highest mortality. So these are very, very dangerous illnesses, and therefore need to have a team that knows what they're looking for. The difficulty with eating disorders is there's no simple test. There's no simple blood test that you can do that you can then diagnose an eating disorder. It's really certainly using the diagnostic codes for sure, but it is an art and a science, and that's where the blood work too will often show up as normal, within normal limits, which does not mean that that person is actually in a healthy place. So there's a lot of subtle things that we can pick up on, and a good PCP who has some training can also pick up on to be able to determine if someone might be struggling. So to know those core pieces, and as I mentioned, they're far more prevalent than we ever thought. And we'll go to our next slide and pillar two. So pillar two, we're talking here about scope, safety, collaboration. And the number one question here is why eating disorders can't be treated in isolation. The key piece here is that they are so complex. They are a biopsychosocial eating illness, meaning there's a biological factor, psychological factor, and of course a social factor. And biologically speaking, we are learning so much more now about the genetic predisposition to developing an eating disorder. We're learning about the actual genetics, genes that could be involved. Right now, we've identified over 100 different genes that could be involved in this process. So as you can see, that means that there's no one specific gene that we would target with gene therapy, for example. But we are seeing more and more this biological piece being a very, very significant part. And in fact, I just had the privilege, honestly, of doing some training in November with Dr. Laura Hill from California on temperament-based training with support. And the focus there very much is around traits and personality traits, and how they can really set our clients up for not just developing an eating disorder, but maintaining it. And one of the big traits that was identified is perfectionism, which leads to a lot of rigidity. And we see that perfectionism and rigidity, black and white thinking, play out with our clients with anorexia. On the other side, we see a lot of impulsivity and risk-taking type of behaviors for our clients with bulimia and binge eating. So there are personality traits that actually kind of tend to go with different diagnoses. So we can't treat eating disorders in isolation because they're far, far too complex for just one clinician and one discipline. If you're only focusing on the therapy, you're missing all the other pieces. And we do know that helping a client get to the why, how did this develop and why, is important work, but not in the short term. In the short term, our focus is very heavily around behavior change because we're talking about an illness that is lethal. And if someone is not weight restoring or is binging and purging and their electrolytes are out of balance, we have a risk of heart attack. And so the why is not important in the context of biological safety and also psychiatric safety. So the why is something that would be something to look at and get to eventually, but in the short term, it really is about behavior change. So you absolutely need in your multidisciplinary team, very, very quickly, you need to have that client seen by their PCP for blood work, extensive blood work. And also we have our clients do an EKG to assess their heart. We're also looking at organs that may be starting to show signs of losing homeostasis and inflammation and in fact damage. And one of those is the liver. We are able to see increased liver enzymes for some of our clients. And interestingly, we will often see high cholesterol in our clients with anorexia. And for those who are unaware of that malnutrition leading to elevated cholesterol, we've had clients who've had so many workups by cardiologists and they've totally missed the mark. It's anorexia that has caused the high cholesterol, which sounds kind of paradoxical. So on your team, you will have first and foremost hopefully an ED savvy doctor, and we can help you there. And absolutely you need an RD on your team who can be helping with this intake of food and helping to reduce symptoms through that. And then yourself, if you feel capable doing the therapeutic behavior change. The therapies modalities that are used initially with behavior change are the CBT, DBT, ACT, are the most common behavioral therapies that are used. Ethical boundaries for new eating disorder therapists. This is what I think we see a lot. Not a lot, I wouldn't say it in that regard, but the concerns like the poll you just filled out, we see new therapists who are wanting to build up their practice. You have this client who may be not doing so well. And we're here to help people, and we're also here to make a living so that we can pay our rent or pay our mortgage or pay off our loans. So I think that there's no shame or harm in just identifying the fact that we deserve to make a living doing something that we love to do. And if your practice is low in clients and you're really worried about money, one thing that can come up is hanging on to your client too long. And do know that the longer you hang on to that client, they're not getting the right care, the worse their prognosis, because the more damage is done to the brain through the inconsistent food intake. And I'm not talking just about anorexia. All of the eating disorders lead to atrophy of the brain and damage to the organs because all of the eating disorders lead to malnutrition. And that may sound again paradoxical because for binge eating, there is a large consumption of food, but actually the body isn't designed to take food in through binges. It's designed hormonally to have consistent intake throughout the day. That's the way that the body is able to maintain homeostasis and to be operating optimally. And so if you're not doing that, the body is under great distress. Ethical boundaries, so that's a big one that comes up for me. And then I think the other piece too that I want to just wave a flag for, many of us in the field, about 80% of us in the field of eating disorders have our own lived experience. For many, many years, we never shared that. We were discouraged from doing so. And that comes, I think, from a psychoanalytical background and perspective, particularly here in the Northeast. In California, they were way ahead of us in sharing with their clients if they had lived experience. And as one clinician put it to me, who actually coached me through this, she said, Mel, if I was struck by lightning, and I had a client who came in and they had been struck by lightning, and they'd never met anyone else who'd ever been struck by lightning and felt isolated and alone, I feel it would be helpful for them to know I have had that experience. And I thought about that and I thought, you know what, that's a good point. So we now know actually that for many of our clients, it's really helpful to know that there are people who go through full recovery. They don't need to know further details, but there are a lot of people out there with lived experience who are now coaching and things of that nature. And so similar to the substance use industry, where, you know, working with a peer who's gone through their own sobriety can be incredibly, incredibly impactful. And so we're a little late to the game in that regard, but we are sharing that more. I'm bringing this up though, however, because you do need to be intentional and thoughtful about how you share that information. And we've seen some of our younger clinicians who are struggling to develop rapport with a client just throw it out there as a last ditch effort to try and develop rapport. That is an inappropriate way to be sharing if you have lived experience. So again, these are just a couple of ethical things that come up for me. Lily, did you have anything else you want to say around ethical boundaries that you're thinking about?
I think just like reduces the shame when you're able to share about your own lived experience. I think that's something my clients have experienced, and also reduces the power dynamic of I know about this thing, but I've never lived it in my body. And I think people feel more trusting of a provider where they know that you've not only lived it, but you've also trained extensively in it. So I think those go hand in hand. I think there's a lot of ethical boundaries here in that if you don't know enough about eating disorders, I think it's okay to say, hey, I think there's something going on here with a client, and I want to recommend that you get more extensive, why can't I think of the word, that you get a more comprehensive, um, evaluation by a person who can ask those questions. And I was seeing in the chat that someone said, you know, what are more of the underlying symptoms that you would notice similar to substance use when you work with that all the time, when they're obfuscating around your questions, what are things you can notice? And I think a really good trained eating disorder provider would notice those things. So I think that's a hard question to answer. And I definitely want to send an email to that person maybe, or if we get to the Q&A, we can respond more fully to that. But I do think the more that you work with them, you start to notice some of the subtleties and nuances, and you become able to cut through their kind of denial and their ability to go around your question. So that's something that just comes with time.
Oh yeah, oh yeah, they're very good at that. Very, very good. And I pointed that out to a client of mine yesterday. I said, you realize you have this very good skill about avoiding this particular topic? And they were like, "Oh, you realize that?" I was laughing internally. Oh, well, we have a good rapport, so we can joke among ourselves, myself and this particular client. Okay, so I know we've got some slides to cover, and I want to get to those Q&As. So let's have a look. Pillar 3. Actually, if you don't mind just going back, Lily, the last one there, because I know that came up in the questions earlier. How to determine if a client is appropriate for outpatient eating disorder treatment. So we go with two key things, medical stability and psychiatric stability. Psychiatric stability is perhaps a little bit easier because it really just means, is this client suicidal? And or psychosis. And if we're ruling out both of those and they also don't have excessive depression to the point that they are not functioning, then if those things are not there, then that would suggest psychiatric stability in a very rudimentary way. Medical stability is a lot harder to determine, and that's where you need a very sophisticated eating disorder PCP to be able to sign off on that. So that's where we want an EKG, because we want to know that the heart is, because remember, when people are malnourished and or losing weight, every single organ in the body atrophies, including the heart, becomes weaker over time. And so we want to make sure that that heart is not going to stop. So you want to make sure medical stability and make sure electrolytes are balanced. You also want to make sure that that client is eating enough to sustain their basic energy needs for the day. So as you can see, there's questions there that may honestly are outside of our scope, so I'm not a PCP, so I can't be, knowing about the blood work, though I will send out for that. And as a therapist, you may ask to get a sense of how much your client is eating, though that's where you may need a nutritionist to kind of help you to evaluate, is this client eating enough, and can we help the client actually make progress? That's the key thing. If the client is able to make progress with you as the therapist and an RD and a PCP all in outpatient private practice, then yes, that is appropriate. If the client is stalling or continuing with their symptoms or losing weight, continuing to lose weight, the answer is no. And so as you can see there, you have to have a team with you to even be able to evaluate that. We'll go to the next slide. So pillar 3, therapist development pathway. And Lily, I'm going to ask you to help me out here with some of your insights. So growing competence, what does that actually look like? From your perspective, Lily, as a therapist, how would you describe that?
Yeah, definitely. I think that's such a great place for clinicians to get more training. So I love the idea of going to, this training and then for jumping off from here, I know Balance has a bunch of CE trainings that are free and all of the treatment centers in New York have a ton of free trainings. So that's a great way to get more comfort and competence with this. I think also talking to other therapists who do work with eating disorders and hearing their experiences of working with these clients, asking them some of those hard questions like what are the subtle cues you look for. Also using the screening tools that we're going to send in the post-webinar email. There are some screenings that you actually can use that don't require you necessarily to ask the questions on the screenings, similar like the GAD-7. There are screenings for eating disorders, so that can really be helpful. The biggest thing that I think we need more competence in is knowing when to refer to an expert. And this is really tricky. And someone asked, how do we navigate subclinical disordered eating, which I see as much, much more prevalent in the outpatient world. We recognize that our clients aren't eating well and maybe are having some disordered exercise. We didn't even touch on like exercise addiction and exercise bulimia, which can be another, pathway to compensatory behaviors. I think being able to recognize, even though this wouldn't meet the criteria for an eating disorder in the DSM, I do want them to see a doctor and make sure that the medical stability is there because we can't, as therapists, by looking at our clients, by talking to our clients, we cannot know what is going on medically with our clients. If your car was making a funny sound, you would take it to the mechanic, you would have them look inside. We need doctors on our side for that blood work, as well as places like Balance, where you can do an evaluation with them and they can share this person is a good fit for IOP or PHP, different levels of care. So I think there's an importance of knowing your limits and knowing when to bring someone on. When you bring on an eating disorder therapist, you don't become obsolete. You become a part of a team. And I think that's where I've learned the most about eating disorders is working with a dietitian, with a treatment center. They're educating me on sometimes the client's behaviors. They're educating me on things I might have missed, things I really assessed well. So I think being able to be open to collaborating with experts is a great way to learn. And there's so many experts out there that you can work with instead of viewing this as like the silos of mental health, which I think comes up a lot.
Yes, absolutely. I agree. And I'm just writing in some answers here to some of these great questions coming in as well that are really, really helpful. Lily,
Yeah.
did you want me to pick it up from there?
No, I can keep going. So I think, yeah, just listing off what's on the slide, the role of ongoing consultation. So getting an eating disorder supervisor can also be a great way to learn more about cases, going to trainings, recognizing the path from like what it looks like in the beginning of an eating disorder to getting like more competent with it and then becoming advanced. That could look like getting your certified eating disorder specialist actual certification. I'm a certified intuitive eating counselor, so there's different certifications you can get. And then how to avoid common pitfalls that new eating disorder therapists face. I think I already touched on this, but the idea that you're going to magically understand eating disorders because you took one training is not true. So I'm not trying to present this as leaving this training, you should be like, I can handle anything with eating disorders. It's more, I'm not afraid of eating disorders. I know that I will need consultation on this. I know that there's resources and evaluations out there that go beyond my scope, but I'm also not going to shy away from asking about food, from knowing even
Yes.
though my caseload needs another client, like this person actually might suffer by staying at the outpatient level and does need a higher level of care. And I think a place like Balance is able to communicate with you while they're still at that higher level of care. I
Absolutely, Lily. Thank you so much. And Lily, a shout out to the Certified Eating Disorder Specialist training. It is through IDAP, that is the International Association of Eating Disorder Professionals. I went to put it in the chat, but I'm aware that you all are not able to see that. And maybe, Lily, are we able to add anything into the Q&A for our audience to see? I'm not sure. We might put that in an email to you all after today's presentation. But IDAP, IAEDP, they have a curriculum that walks you through the basic foundational information that you should know to become a certified eating disorder specialist. And then after you've completed 3,000 clinical hours, which takes about three years if you're working full time with this population. So 3 years of clinical with supervision, you can become a certified eating disorder specialist. And then some of us are also supervisors, which is another 1,000 hours. So that is, if you're really thinking to become advanced in this training, that is the certification that I look for when I'm looking to link my client with a therapist, with an RD, with a PCP, that our doctors get the same certification. I'm looking for that because for me, that's shorthand to know they know what they're doing. And so I would encourage you, if you are really interested in this area, to do that. And if that's a little bit too involved, as Lily said, just doing a few more courses and webinars. And the one book I would highly recommend, it's called Sick Enough, and that's by Dr. Jennifer Guardiani. And again, we'll put this in an email out to you all. Jen used to work at Acute Denver. Acute Denver is the only eating disorder inpatient hospital in the country, and they treat people with BMIs as low as 10. And that is when you would see that stereotypical skeletal looking person who looks like they probably shouldn't be alive. They do tube feedings and TPN feedings and very, very complicated work there to try to bring people basically back to life. So those are just a couple of things. So Sick Enough and IDAP and the certification program there. And we'll go to our next slide. So what does competent ED treatment look like? A non-ED trained therapist's conceptualization is just like anything. When you're not trained in it, you just don't have the lens. So you can't see the nuances, and you may be just therefore focusing on the symptoms. Your client comes in and says, I'm really anxious about this, and I've got a presentation and my relationship and my work or my school, and you're focusing on all of those day-to-day aspects of their life, which are important, but we're missing the foundational piece, which is this person is grossly malnourished and using very, very, very unhealthy, dangerous behaviors to help them to manage their emotions. And an eating disorder informed therapist or RD or professional is thinking about, okay, let me think here. What's the medical risk? What does the blood work look like? Let's have a look at those behaviors. Is there a lot of isolating going on here? Is there a lot of omission going on? Is there a lot of bandwidth spent, preoccupation around food and calories and body image and weight? The motivational ambivalence is a hallmark of an eating disorder. And this is perhaps one of the most excruciating pieces, right, Lily? Because our clients can come to us at a time of great distress and say, I just can't take this anymore. I'm sick and tired of being sick and tired with this eating disorder, and be highly motivated in that moment. And then the next day that window has closed. And they're back into the denial, the rationalization, oh, I'm not really sick enough, which is why the book is called Sick Enough, because that's probably the number one thing our clients say, I'm not sick enough, when in fact they abundantly meet criteria for an eating disorder. And an ED-informed clinician is also looking at the idea that we definitely need a team to make sure that we are doing the best for the client and we have eyes on all these different areas. So key teaching moments, subtle eating disorder behaviors are certainly very, very easy to miss, as I mentioned. They will be in your sessions and you probably won't know. And please, that is not your fault, because unless the client really tells you, you're not going to know. You really are not going to know. And why clients often look fine, but they are not. Again, it's because very few people end up in that skeletal state. And it's really about kind of like, with a car, you can't really tell if a car is a good car or not until you look at the engine, and we can't see internally what's going on, obviously. And that's the only way that you will know. And ED-informed treatment leads to better outcomes. I cannot emphasize this enough. The sooner a client gets into good treatment, the better the prognosis. If we miss that window, we know that clients can go on for years and even decades before they come back for treatment, if at all. And one of the heartbreakers for me and the field is statistically only about 10 to 15% of people with full-blown eating disorders ever get treatment. And I'm hoping that through raising awareness, and if all of us are screening, whether we're treating eating disorders or not, we can identify people who need treatment and get them the care that they need so that we can improve that statistic. Part of that is, of course, the screening and being underdiagnosed. Part of that is also access to care. But at the very least, I think if we do a better job at screening, we can make a real impact on that statistic. We'll go to our next slide, Lily. So when and how to refer to a high level of care, why level of care decisions matter. So as we know, eating disorders can become medically dangerous really quickly, especially if someone is in the initial weight loss period or there's a symptom progression. In those periods, their internal electrolytes are very unstable. And this is where we worry about people, with very low heart rates just not waking up in the morning. Or we worry about someone with their potassium dropping, having a heart attack in their sleep. Or we also have clients who, are so low on fuel intake, they have a hypoglycemic event, which means your blood sugars are so low that the body, we faint in order to remove gravity from that equation so that the little glucose that is left in the body is going to the brain to keep you alive. When you pass out, you could easily hit your head, you could fall in traffic, you could, fall onto the subway rails. So very, very dangerous symptoms there as well. And from yourself, Lily, when you think about outpatient work alone and conversations that you may have with your team around, do we refer up? How do you all go about making that kind of a decision?
Yeah, I think that's on the next slide, I believe, so we can
Oh,
pop.
okay,
But
go
yeah,
there.
I think that's on the next slide.
Yep.
Yeah, so I think what we try to think about is being honestly on the cautious side. Like, it is great to get an evaluation because all of these factors that you're stating here, medical instability, behavioral indicators, psychological factors, functional impairment, all of these things can be assessed from different people. So if I assess for these things, I'm going to have one perspective based on the things that I see. But if we also bring in a doctor, if we also bring in Balance Treatment Center, we can get a more comprehensive view of what's going on with the client. And then we can figure out what is the best level of care. So I err on the side of caution. And I think maybe it's actually the next slide that talks about, when we're going to refer to a higher level of care, which looks like referring to intensive outpatient treatment, partial hospitalization, residential or inpatient medical stabilization. And what I love to do is talk to clients about I don't want to make the decision about what is best for your treatment, but my alarm bells are going off that you might need something more than outpatient treatment. So, getting the evaluation is a really wonderful step in figuring that out. When you do an evaluation at a place that has an IOP, a PHP, and a residential, potentially they can say, hey, this person actually is a good fit for outpatient. We don't think they need our IOP, or we do think they need our IOP, or they need PHP, and these are all different levels of care. IOP is like a 3 to 5 day a week program for a few hours. PHP can be more of a full day program. You guys have probably heard of these terms with substance use, very similar. And residential is where you go and you live at the actual house and they're feeding you all of your meals while you're there. Inpatient medical stabilization, the closest one on the East Coast is Princeton, and then there's acute in Denver. So for me, I like to think about using a more cautionary way of saying this, like you can get this evaluation, we can come back together, and then we can talk about the recommendation the same way I would do with a psychiatrist, which I actually think is on the next slide. So we can jump ahead. I know we're jumping ahead, but we want to get some Q&A. So this is a great script for what I might say. Your symptoms are showing us that you need more support to heal. This isn't a failure. This is about your safety and getting you the level of care that you deserve and that will help you recover. I'll stay part of your team and we'll navigate this together. And this reduces the fear, the shame, the resistance, the confusion. We're getting this evaluation so that we can get you to the right level of care as quick as possible. When we delay treatment, I think Mel touched on this earlier, that can really reduce the treatment effectiveness. So the sooner that we get someone to care, the more likely it is that we're going to get them to fully recover and they can come back to work with us once they've completed an IOP or a PHP. So I err on the side of caution. I think one of the questions in the Q&A was really important. Those subclinical disordered eating cases, honestly, a lot of the times disordered eating would fall into the eating disorder full diagnoses. So again, I would say if you're not comfortable for sure saying this isn't a clinical eating disorder, it might be an err on the side of caution because these are very serious and very deadly disorders. And something Mel said earlier, which is so important, is just how quickly it can shift. I've seen a client in the outpatient world be totally fine, blood work is fine. I didn't know there was purging going on. And something we didn't mention, I didn't know laxative use was going on because a lot of people aren't going to admit that. Things can shift quickly. And if you already have a doctor on board and you already have the evaluation process started, there is so much more likeliness that they are going to get the treatment they need. So I think we can go to the next slide, just picking up
Yeah.
the pace. I know we only have 9 minutes left. So
Yep.
yeah, this is going off of more like when and how to refer to a higher level of care, coordinating with the PACP, consulting with a dietitian. So Mel really touched on that, like therapist, dietitian, PCP, higher level of care. So balance is a great option to refer to, and we'll have more on a slide later on how you can do that. I like to really hear the program recommendations from the treatment centers themselves because they are the experts. They're doing this day in, day out, assessing people, picking up on those subtle cues. Even as an outpatient therapist who has been doing this for 8 years, I might miss something. We need someone else to also be looking at this case. During treatment, it's really important to stay in touch with the treatment center to support the skills that they are building and help with the emotional integration once they are out of treatment. That's a really great way to have relapse prevention, have more support, and have ongoing monitoring. So that might look like consistency with their doctor after, or working with a dietitian who uses like a blind scale at home. Clear Step is a great option. You can look into that later. It's a great way for clients to get weighed that doesn't involve them seeing any numbers, and the numbers are directly uploaded into a portal that only the treatment providers can see. So there's a lot of really interesting things going on in the eating disorder world that make treatment so much more accessible. And as the outpatient therapist, the number one thing you have to do is get them to the evaluation, get them to the PCP, share that that's an important piece with them.
And I will say there, Lily, yep, as we jump into the QA, one thing not to do, team, is take it upon yourself to have that client start eating again. There is something called refeeding syndrome that is very lethal, whereby if a client starts eating and they haven't been eating, their potassium, their phosphorus, in fact, can drop, and it can lead to edema, and it can lead to kidney failure and death. So again, either way you go about it, you really need to have a wraparound team making those decisions. Don't attempt that on your own. Let's jump into the Q&A.
Yeah, I feel like some of these we can rapid fire. So,
Yes.
David, you said, is it the gold standard for communication at treatment centers to expect for treatment centers? I think you're saying, is it the gold standard to expect them to communicate with outpatient providers? I would say yes, that is the gold standard. If you're an outpatient provider and you're not hearing from the treatment center, be
Call them.
aggressive, reach out to them, call them, make sure you're letting them know that you are a provider for this person you're not hearing, obviously with a release of information in place. So that's really important and I think makes the treatment outcomes a lot better. I think we handled the one about subclinical types of eating disorders. They might not raise to the level of diagnostic criteria. Is Yeah, I think finding the right support could mean continuing to work with their outpatient provider. I've also seen a lot of great work when someone calls me and says, I have a therapist I've been with for years, but I want to bring you on for a few months to just really tackle the eating disorder. And I'm happy to collaborate on cases and then be able to step away and say, hey, I think we did some good body image work. We did some good, like values work around eating disorders and how people feel about food, and then maybe add in a dietitian too. That could be a really great resource because a lot of dietitians do a lot of that body image work and it doesn't step on the toes of the current therapist. It actually adds to the work. So I think that's a good add-on. I don't know if
And
Mel, you have it.
yeah, and a really good treatment team. We're not trained in how to work as a multidisciplinary team, but a good eating disorder team will be communicating weekly. The therapist, the PCP, even the psychiatrist and the RD. So we have a group email that we're sending. So for example, Lily, if you referred into us, all of us would be sending a group email to you so you're updated. And then actually we like our clients to stay with their referring therapist while they're still with us, because you're their kind of anchor person and you're the most familiar with them. And you also are able to kind of look at all other aspects of their life while we're focusing heavily on behavior change and what's going on in treatment. So that's also a really nice coordination there.
Definitely. Another really good question in the chat. How do we help a client in a larger body advocate for higher level ED care, especially if they are showing symptoms more aligned with anorexia than binge eating? Oh, this question breaks my heart because I think people in larger bodies, we didn't say this earlier and I meant to jump in. Often people in larger bodies are actually prescribed restrictive eating disorders by their doctors.
Yes.
You are in a larger body, it is very, very hard to have a doctor understand that you are actually struggling with anorexia and restriction and not binge eating. And I think atypical anorexia is actually has a higher mortality rate, or there's something about the mortality rate of atypical anorexia being worse because of this misdiagnosis piece. So I've seen a lot of the treatment centers do a much, much, much better job at assessing people for symptoms and not assessing them based on their expectations or their body sizes. And I will say I have referred often to Balance and currently have a client at Balance, and they are so collaborative and communicative. And I was able to share with them before the client even spoke to them, here's what's going on with the client. So when they're met at the treatment center, they aren't facing this experience of someone assuming what their eating disorder is. And I think it's much harder when you're in a larger body. And I would just encourage my clients. I sometimes give them like a little note card with what they can share with their doctor, or I try to get in touch with their doctor to support them in that. But that's a really tricky one.
Yeah, oh my gosh, absolutely, absolutely. And need such important care in such a society where weight stigma is so prevalent. There's another one here from Laura. Oh, sorry,
I
there
think
was
we have to go to closing slides because we,
oh,
we
we
have
do.
2 minutes
Let's go to
left, but
closing
we are
comments.
gonna follow up the questions.
Ah,
We took a screenshot of the questions and we're gonna follow up in text with the questions. And if you have any other questions, you can always send them. But go ahead, Mel.
Thanks, Lily, for keeping us on track. So, this is a little bit about balance. If you're wondering what we do, we have 4 levels of care, starting with partial hospitalization, which is 30 to 40 hours a week, 7 days a week. That does require medical leave, usually from school or work. So, it is the next level just below residential, which is 24/7 care. So, this allows our clients to still live at home, be at home, still be with family, etc. The step down from that is called an IOP, or intensive outpatient program, and that's anywhere between 9 to 15 hours a week. Our clients in that program can go back to work, go back to school, and still be engaged in daily life. I will say that we also do have individual nutrition therapy. So, as therapists, if you need an RD to join you and continue one-on-one, we're able to support you in that. And we're also able to help bring in a PCP, an eating disorder PCP. We're very connected. There's only about 5 or 6 of them in the city, believe it or not. And this is New York. They are very, very few and far between. And if our client is working with a PCP, which most hopefully do have one, or a pediatrician, we're able to call those docs and let them know kind of what blood work and what testing we would want them to do, so that we can subtly discern those eating disorder labs that may tell us a little bit more. So those are some of the services that we offer. We're right here in New York City on 21st Street, just off Fifth Avenue in Chelsea, and we treat all of the different eating disorders, including ARFID, which used to be called picky eating. It's one of our areas of specialty, as is binge eating and atypical anorexia. My specialty is working with clients in higher weight bodies. And you can scan our QR code there. If you need any further resources, you can reach out to Lisa, who's here on the screen with us as well. And she can walk you through intake and setting up an assessment. And over to you, Lily.
Yeah, thank you so much. So this is my practice. We are on 37th and Lexington, and we operate in New York City for in-person sessions for outpatient therapy, as well as virtual sessions in New York, New Jersey, Massachusetts, Connecticut. And if you want to email me, really truly email me. I respond to all my own emails. I'm happy to answer some of the questions that were missed or try to direct you to the right person. Follow me on Instagram. I try to post on there about trainings and things that are coming up. Here's my website. And then I do run an in-person group. So if any of you are in New York and you have clients who are in, recovery or have some sort of history with dieting or eating disorders, this is a free dinner in New York City to meet other people who are wanting this anti-diet space, a judgment-free zone, and just a place where we can practice eating at different restaurants and exposing ourselves to that. And I co-host it with an amazing dietitian who's also in a larger body. So we really try to be thoughtful about finding spaces that have inclusive seating and all of that. So that's all on my website. And if you want to email me, I'm happy to chat more. Thank you so much for coming and for being at this important webinar and learning about eating disorders. And I'm really excited for more people to work with eating disorders because I think it's given me so much working with them. And I think everyone can benefit from it.
Yep. Thanks, Lily. Thanks,
Thanks,
Lisa.
everybody. We will send out an email on Monday with all of the resources, including screening questions, answers to all of the questions y'all provided, and a few more materials. So keep an eye out on Monday morning. You will have that in your inbox. But thank you, everybody, for our first 2026 webinar. And thank you, Lily and Melanie. Y'all were wonderful.
Thank
Thank
you.
you so much.